Hello, everyone. I'm Solomay Tibabu, and I'm the host of Going Digital Behavioral Health Tech. Population health and precision medicine, two areas that clinicians, pharma, and healthcare organizations have been working on for years. According to the American Hospital Association, 82% of hospitals and health systems have incorporated population health management into their organization strategies. And while precision medicine isn't yet widespread, surveys show that a strong majority of patients view precision medicine favorably. The time has come where our ability to combine both of these disciplines as precision population health approach holds promise for better outcomes, lower costs, and higher patient engagement. Today, I have the pleasure of speaking with two experts in the field of population health management and precision health, Cynthia Kilroy and Dr. David Krause, co-CEOs of Genomind. Thank you both for being here. Cynthia has been at the forefront of creating systems of value-based healthcare, working to help organizations shift their economics from fee-for-service to value-based outcomes through population health. Her experience goes all throughout healthcare stakeholders, including providers, payers, ACOs, digital health, and telehealth. And Dr. David Krause is a board-certified internist who has more than 25 years of experience in clinical science and who has held leadership positions at multiple pharmaceutical companies and has been Genomind's chief medical officer since 2017. I'm so excited for both of you to join us today. Thank you so much. Why don't we jump right in? Cynthia, I'd like to start with you. What is precision medicine and how does precision medicine and population health align exactly?
Just to level set, let me start again. Sorry. Salome, it's really great for us to be here today. I'm really excited about the opportunity for precision health and what it can do for the industry. Just to level set, though, we look at precision medicine around the ability to identify an individual's genetic characteristics and match them to a particular treatment and to medication options. Why is precision medicine important? Everybody's genetic makeup is unique. Suboptimal medication uses are linked to 275,000 deaths and waste over $5 billion every year. That also includes 3.2 million hospital visits and ER visits due to adverse drug events, and it's the fourth leading cause of death in the US. And finally, and we're going to talk a little bit more about the mental health side and why precision health is very important and precision prescribing, is that the trial and error and the one size fits all doesn't work. And that more than 2 million individuals have adverse drug events due to this trial and error approach. What I think is really interesting and talk about how precision and population health align is the American Hospital Association in 2021 came out and said, precision medicine and population health are complementary concepts. Outcomes data gleaned from precision medicine can fuel population health programs by identifying, screening, and risk stratifying individuals who would benefit from particular preventative care and treatment protocols based on their genetic makeup.
Thanks so much, Cynthia. I can't wait to ask you more about that. And just so for the audience who might not be familiar, who is Genomind and what do you do?
So we are a precision health company, and we use technology, data, and science to optimize drug therapies and improve patient outcomes by looking at the value of genetic data to create actionable and targeted interventions at an individual and population level. So what Genomind does is we actually can ingest information about a population, and we can identify those individuals that have a drug-drug interactions, and then we can impute those individuals that would benefit from a genetic test. And from there, we can actually work with care managers, we can work with ACOs, other organizations to identify those individuals, do outreach, and get the genetic test. From there, those individuals, after they have been tested, we can actually then work with the physician to provide insights into what the recommended medications are. We do that across all therapeutic areas. Not just mental health, but we do this across all therapeutic areas. We've worked with over 14,000 physicians across all specialties. We work in inpatient, outpatient, rural health. We have partnerships with ACOs, collaborative care organizations. We actually have a lot of interest from a long-term care perspective, and we're working with digital health companies and telehealth companies, really helping them optimize treatment recommendations across a diverse population. So if you think about a use case, right, how we think about it from a population individual level, right? By 2030, there will be more adults over 65 than children. Let's talk a use case that can impact both an individual and a population. By 2030, there will be more adults over 65 than children. Half of those adults over 65 will be taking 5 or more prescription medications, what we call as polypharmacy, which everybody knows here. Polypharmacy, it's a cocktail of medications that have unintended side effects. According to Kaiser Family Foundation, a recent report, over the next decade, there's an estimated 4.6 million hospitalizations that come from polypharmacy. So we can look at populations from an ACO or an employer or from a payer and identify those individuals that have a drug-drug interaction. And then we can identify those individuals that could then benefit from the genetic test. From there, we can actually identify how we could actually change the medication regimen for that individual to reduce those adverse events. And this is personally important to me. I have a mother that has Parkinson's, she has dementia, and she has anxiety, and she was on 15 medications, and being able to actually identify the right medications and how those drug-drug interactions occur has really been helpful.
Thank you so much. I'd love to follow up with a few more questions, but before I do, Dr. Krause, I'd love to turn it to you now. As Chief Medical Officer and co-CEO, what are you seeing that's encouraging in terms of adoption and really the science of precision health in the market?
Well, thank you, Salome. First of all, it's great to be here, and thank you for having us and allowing us to present. When I was in medical school in the dark ages in the 70s, we talked about the promise of personalized medicine and decoding the human genome. And of course, fast forward now into 2022, and that promise has turned into reality. So we have the tools now, and now it's all about implementation. As you know, or as you may know, Genomind was founded by a psychiatrist more than 10 years ago, Dr. Ron Dezoritz. And Dr. Dezoritz had a vision about precision medicine, pharmacogenetics, taking pharmacogenetics to psychiatry and mental health. And he was well ahead of himself, but the world's catching up. And there have been huge changes that I can see in the market, in acceptance, and in adoption in my 5 years at Genomind. There are hundreds of drugs that have genetic biomarker implications in their labels. And psychiatry is the second most common therapeutic area after oncology for those gene-drug associations. So these associations have important therapeutic implications. And in fact, the FDA has said that pharmacogenetic tests, along with other information about patients and their disease or condition, can play an important role in drug therapy. So we certainly agree with that. And with respect to adoption, from a regulatory perspective, Congress has been surprisingly involved. And right now, the Right Dose Now Act is being crafted in the House of Representatives with bipartisan support. We're hopeful that this act will be passed later this year. And this act will provide funding for provider education, integration into electronic medical records, funding for the NIH to better integrate pharmacogenetics into patient care.
And what about payers and employers?
Yep, there's been a lot of changes there in the last several years as well. First of all, in most states and territories, Medicare has approved a local coverage determination policy, which covers pharmacogenetics specifically for neuropsychiatric conditions. So that's hugely important. There are 45 states where Medicaid covers pharmacogenetic testing in certain circumstances. And in 2019, the largest commercial insurer in the United States, United Healthcare, issued a coverage determination policy in which they agreed to pay for pharmacogenetics for mental health. So the field of play is changing rapidly, and employers and employer benefit brokers are noticing this and beginning to cover pharmacogenetic testing. This is all in recognition that the pharmacoeconomics of pharmacogenetic testing makes sense.
And what do you see the biggest opportunity to help drive outcomes?
The biggest opportunity is clearly in primary care. So we know that most prescriptions for mental health are written in the primary care setting. And those providers will write about 79% of antidepressant medication, for example, and treat more than half the people who are being treated for depression in this country. And they do that with little support from specialist services. There's a shortage of mental health care providers in this country. Most psychiatrists in this country are over the age of 50. Psychiatry is not a particularly popular subspecialty now among medical students and residents. So we can help primary care providers identify drug-drug and drug-gene interactions. And although our assay focuses on mental care, we have software embedded in our assay, which is a clinical decision support tool. And that allows for the genetic implications and drug-drug interactions of more than 800 drugs. So this is also a global phenomenon, and we have partners in 18 countries. Pharmacogenetics is coming of age as we speak.
Right. This is really exciting traction. And I can see how precision health and testing specifically is important to the treatment of mental health. But I'd love to hear more from your perspective on, do you have any use cases and results that you could talk about?
Salome, we're in a twindemic. We have the COVID pandemic and we have the mental health pandemic. And sadly, our children and young people are disproportionately affected. The incidence of suicide in teens and adolescents increased by 50% from 2019 to 2021. It's an astonishing epidemic. I mentioned that there was an inadequate supply of providers for these kids. And as a result, we're seeing primary care providers, pediatricians, and the rise of digital companies, what this meeting is all about, delivering mental health care by telemedicine. And of course, all this is complicated by the fact that not one size fits all. And there are many choices, for example, of antidepressants, but we know that you can't predict for an individual patient what that patient will respond to based on clinical implications alone. And it can take weeks to achieve response or remission. And in fact, most people don't achieve remission on their first go round. So the whole idea of pharmacogenetic testing is to get better faster, get our patients up and running faster, and increase the proportion of patients who will experience a remission, meaning essentially a complete resolution of symptoms. In 2015, we sponsored a case control study that was performed by writers and scientists at Stanford University and Massachusetts General Hospital. We did a case control study in Aetna's database. And it turned out that there were 1 million people in Aetna's database in those years who had mood disorder. And it so happened that several thousand of them had got tested with our Genocept assay, a predecessor of our previous result. And we did a case control propensity score match study, which showed that hospitalizations decreased by almost 50%. There were 40% fewer emergency room visits. And the patients who got tested with our assay cost about $2,000 less per patient in 2015 dollars. So we can use these real world data. We have used these data to model other populations. And when we do so, we find that the greatest saving is among individuals, as Cynthia mentioned, with polypharmacy and with mood disorders. There was also a recent meta-analysis from the United Kingdom, which looked at 5 studies incorporating pharmacoeconomic data, one of which was our study. And in a variety of settings, primary care, mental health, seriously ill patients, it all prevented, pharmacogenetics prevented rehospitalization by about 50%. So again, this is the promise of pharmacogenetics. All the pharmacoeconomic data point in the same direction.
Wow, that's remarkable. Thank you so much, Dr. Krause. And now, Cynthia, I'd like to turn it back to you. As someone who has innovated in the value-based care market, why is precision medicine important to improving quality and costs to payers, ACOs, and employers?
So, I've spent a majority of my career in the value-based care side, and I think about the quadruple aim. I know we talked about it a lot, but as David illustrated with the Aetna study, we have lowered ER visits, we've lowered inpatient visits. We have improved patient satisfaction. Majority of patients that come to us feel that they have, had positive results working with their physicians. And it allows the provider to be more efficient, to treat the patient in a more effective manner. So, when you think about our population health solution and we can take in, a data set and data file, we risk stratify those individuals. We can take in a file of medication for those individuals. We also like to bring in the age, the diagnosis, and the ethnicity to the individual, and we can then identify those drug-drug interactions. But then, as I said previously, we can impute those individuals. And I think one of the biggest challenges with pharmacogenetic testing is when and why and how do you do it, right? And so, there might have been people that wouldn't benefit, but the goal of our population technology and precision health technology is to identify those individuals that benefit. So we can risk stratify those individuals to then identify who we want to reach out to and who we want to actually have an intervention to, and then change those medications, working with the provider to actually drive down costs, but to improve, treatment. We also have a really interesting solution too. So we can do that on a population level. But one of the other things that we do bring to the provider at the practice is we have software that they can actually do scenario modeling. They can do it for all drug, so just for a patient, if they've been a prescriber to us, but then we can actually bring in their genetic information and they can actually look at, okay, you're on this SSIR, but you're actually on Lipitor, you're on this. And they can actually, based on that genetic, say, this is what I'm going to actually prescribe. Maybe I'm changing the dosage. Maybe this is not the appropriate medication for you. Maybe this is a better SSIR. So, that is actually, I think, something that's really differentiates us, that we are actually, working with the provider too, to change, how, change the medication. And so what do I see as the value proposition of population health? Obviously, we talk about it improves medication management. We talked about the baby boomers, but a lot of the tests that we've done of our 300,000 individuals we've tested have also been adolescents across all diagnoses. So, we go across multiple diagnoses: depression, anxiety, ADHD, autism, and many, many more, bipolar, PTSD. And so, when we look at this, it's not just seniors, it's the young individuals too that David identified. So, when you use that framework and you bring in precision medicine into, the treatment of patients, the value proposition is that we get the right drug at the earliest possible time to reduce waste and improve outcomes. We actually remove the disparity in care. We talk about that a lot, but individuals of different social settings, there is a disparity in care, especially in the mental health side. So we're looking at that and we're taking that away by tackling the severity of illness through risk stratification. We can actually tailor it to the interventions of high risk groups, different cohorts. We can also identify those high-risk individuals that would benefit from the testing, but also one of the things that we also do is we bring in pharmacists that can do a consult with either a care manager or a physician and really deep dive into the report that we provide to that provider to really understand what is going on with this patient. And that patient can actually join that consult and work with the physician to make the changes.
That's really neat. Thank you so much for outlining all of these great facets of the work that you're doing at Genomind. I know that Genomind can move from, as I understand it, a very high level of population health and utilize genomics to personalize treatments for a singular patient using PGX. Cynthia and Dr. Krause, please, how are you seeing precision medicine improving the individual patient and provider relationship?
So I'll just take from the patient side is that, precision medicine, it's really about empowering the patient. And the primary objective that we found is really educating those individuals and having them understand the value of it, and then ensuring that they get the right access to care. We spend a lot of our time educating the market around precision medicine and our patients. We have thousands of patients each year that come to us looking for solutions. Every week I get some kind of a response from a patient thanking me or thanking Genomind, not me, and the team for really getting them on the right medication. I just received one where she had been tested in 2013 and she actually took the time about 2 months ago to actually come to me and talk to, send an email to me and say, I'm so thankful. My life has changed since I got the test and I'm on the right medications, and kind of walk through the whole scenario. So, I think this is just, an opportunity for patients to get more involved with their providers. David's going to talk a little bit about that. One note is we do take privacy very seriously. I know that's a lot of questions around, testing. We do not share the information. We believe that is, not something that we do. Our database is private, and we only do it for research purposes, and it's de-identified. So that's just something that we really believe in as a genetics company.
Dr. Krause, how about you? Would you like to add to that as well?
I'll just start with a couple of misperceptions about pharmacogenetics. Number one is that it is not a diagnostic test. So we're really agnostic with respect to diagnosis. It's about what drugs are being chosen, not about the diagnosis. And the second misperception is that it's not the Academy Award. So we're not going to open up an envelope and say, this is the one right drug for you. Really what we are is another tool in the provider's tool belt. And we know that there are many factors which will determine what pharmaceutical therapy is appropriate for a patient. So patient history, family history, social determinants of health, provider experience, and so forth. And we want to partner with our providers. And to that end, as Cynthia mentioned, we're very fortunate to have a cadre of really expert pharmacogeneticists who work with us, and we offer a consultation with every assay. And we have performed more than 16,000 consultations, and we recently published the results of these consultations. And so about half the time we're joined on the consultation by the patient, but we don't speak to the patient without the provider being present either. So our role is to make sure that, or to help patients get better faster. And to that end, Cynthia already mentioned our clinical decision support software that we call GenMed Pro, in which a physician can test drive essentially an infinite number of permutations of drugs. So, that's where we are with pharmacogenetics in 2022.
Fantastic. Thanks so much. And you both condensed so much great information in just 30 minutes. I wish we had more time for so many more follow-up questions, but I would like to invite the audience to learn more about this great work from Genomind. If you're an individual, a provider, ACO, employer, health plans, this is really excellent work that is transforming how we're prescribing, ultimately getting individuals the care that they need faster. So thank you both so much for not only your time and expertise, but doing the work that you do.
Thanks, Salome. It's a pleasure.